Good evening. Welcome to My IVF Answers in the European Fertility Society. We are back today with another topic. We will talk about male factor and, of course, how to overcome it. As you can see, we have our first specialist with us already. Dr. Laura Garcia is with us today instead of Dr. Angela, simply as Dr. Angela had some voice problems. So, of course, Dr. Garcia is here just to give us this talk and, of course, explain everything and, as always, answer all of your questions. Dr. Garcia, thank you so much for joining. I'm glad that you were able to step in today, and I'm sure you will be an excellent helper here for us. So thank you so much, and hope that you are having a great day and are ready to educate us a little bit more, as always.
Thank you very much, Caroline.
Good to see you for sure. Let me just remind everyone that Dr. Garcia is the medical director of Clínica Tambre in Madrid. And as I've mentioned before, we will talk about the male factor, which is very often neglected. So today we will definitely focus on this aspect as well. So thank you everyone for joining. And we will start with Dr. Garcia's presentation on our topic. But afterwards, as you know, there will be time for your questions. So put those in the chat so that Dr. Garcia can simply answer them for you one by one. Don't hesitate. This is your time. This is your chance to get some opinions and, of course, second opinions as well. So anything that's on your mind, don't hesitate to simply put that in the chat. And I think that it's best to simply go ahead with our presentation. Dr. Garcia, are you ready to explore our topic today?
Of course.
Perfect. That's great then. Let's go ahead with the presentation. Thank you so much.
Thank you so much, Caroline. Okay, so today we will talk about how important is male factor and how to overcome that. We know that we are always focusing mainly in age, quality of eggs, but of course, it's so important to increase chances, also trying to improve the sperm, trying to really diagnose if it is a male factor that is affecting our project of having a baby. What will we cover today in our presentation? We will talk about your first steps at Tambre, semen analysis, what is involving, karyotype tests, complementary tests for specific cases, potential reproductive solutions in male factor, and conclusions. And of course, later on, we will have time to solve questions. So how is it going to be your first time in Tambre? So you will have a first visit appointment with our fertility expert, Dr. Angela, that unfortunately has voice problems, or Dr. Marvin, or Dr. Bechtel, or even with me. We will have a full anamnesis and diagnostic tests, including, for instance, semen analysis, karyotype analysis, ultrasound, wherever it's necessary for your case. And of course, if necessary, we'll have an appointment with our urologist. And of course, very important, before the consultation, if you are an heterosexual couple, we will ask you to give a sperm sample to test and freeze for the future, just in case we cannot use fresh sample, or because we want to use specific filters in your case. In the semen analysis, we will take into consideration general appearance of the sample, pH, volume and consistency, concentration of spermatozoa, motility, and morphology as well. And of course, you will have a report the same day with all that information. We know that semen can have variation from the one day to another, but we always recommend having an abstinence of around 3 days and confirm with the laboratory that you're not taking any drugs and any medication, and that you haven't had fever for 2 or 3 weeks ago. So terminologies that we use for commenting the result of the sperm, we have a spermia if it's a complete lack of semen, that it could be because of very important stress, but normally this is lead to problems, to really obstructions, or to problems where the testicle is not producing sperm at all, or even genetics disorders. Asthenospermia, when we consider less than 32% of mobile sperm, or less than 40% general mobile sperm. So if we talk about motility progressive, it's less than 32. General motility is less than 40. Azoospermia, it's when we have an absence of semen cells in semen. Hypospermia is when the quantity, the volume, it's less than 1.5 milliliters. So in this context, we need to make sure if that was a problem during the sample, because it was a challenge to introduce all the samples in the recipient that we give you, or if that was a problem during the ejaculation. Oligozoospermia, when we have concentration less than 15 million per milliliter. It could be we have 13, 14, so very in the limit, so it's not that important, but very severe oligozoospermia when we have less than 5 million or even less than 1 million per milliliter. Necrozoospermia is when we have less than 58% of dead spermatozoa in the sample. Teratozoospermia, more than 4% of sperm should be abnormal. So if we have 3%, 4% of all spermatozoa are normal, that is okay. And we don't worry if you don't have more than this, because if it is an expert understanding the morphology of your test, we don't expect to have 80% of normal spermatozoa. But if by contrast you have a 0, you have a 1%, this is going to worry a little bit more. And leukocytospermia, when we have more than 1 million of leukocytes per milliliter, which could be a reason of genitourinary infections, and we need to exclude this kind of problems. If the results are abnormal, the test must be repeated ideally, but we understand, of course, that logistically it's not that easy. But very important to confirm the sample collection time, because if we have a low mobility, it could be that the recipient of the sample has entered in the laboratory like more than 1 hour after the ejaculation. As I said, if we have low volume, it could be that we lose some of the fraction of the sample. It's very, very important to confirm the sexual abstinence. So very short abstinence, less than 24 hours, or long abstinence, more than 7 days, could affect the sperm analysis. The ejaculation frequency, also to take into consideration the last fever period, the intake of medicines or drugs, and also important, the current occupation. It could be that we are exposed to any toxics, such as people that is a painter, for instance, and it could be the reasons for abnormalities. So we also require for all male having treatment in our clinic to do karyotype, especially if they have never had previous children. Karyotype is the individual's group of chromosomes of every single human. We do it with a blood test, and it is important test to be requested before treatment, because supposedly if we have abnormalities in the karyotype, we are more frequently having problems in the sperm, such as oligoteratozoospermia, astenospermia, but it could be some patients having completely normal sperm, but chromosomes disorders that whenever we use their sperm, we are at more risk to create abnormal embryos. So we used to look for abnormal numbers or structures of chromosomes such as translocations and other genetic issues such as inversions of the chromosomes. And we ask most of our patients to have it analyzed, but it's not compulsory to start the treatment. And as I said, if it's not easy to have this karyotype test done in their country and they are not coming to Madrid before doing the treatment, and they say they have had children, supposedly the karyotype should be okay. The frequency of abnormality in the karyotype is less than 1% in human population. Complementary tests. We can ask biochemical analysis of seminal plasma. So seminal plasma is a combination of secretions from the epididymins and other glands. The fructose results from the seminal vesicles, maltase present in the epididymis, and citrate from the prostate. So if we have abnormalities in the sperm and we ask for this biochemical testing, we could be able to talk with the patient and the urologist where we think it's the problem, if it's in the seminal vesicles, in the prostate, etc. Not all clinics perform this test without having to outsource it. As to obtain the plasma, it is necessary to rely on an automatic analysis, biologists who know how to use it, and a specialized unit to interpret the results. Another possible complementary test is the COMET fertility. This is a test that allows to evaluate the percentage of fragmented sperm in an ejaculate. The fragmentation refers to breaks, interruptions in the DNA brain, which is composed of 2 standards and 1 standard depending how it is in every single spermatozoa. And the normal levels are below 60%. If the genetic content is damaged, if we have a lot of interruptions of the DNA, we can have problems with failures or miscarriage. If the damage occurs on one of the strands of the double helix, we are dealing with single-stranded fragmentation, and if it's present on both, it's called the double-stranded fragmentation. So you can see the helix of the normal DNA, spermatozoa, and we can see interruptions in the simple strand fragmentation and in the double strand fragmentation. So single brain abnormalities could be reasonable to related to failed IVF or incorrect fertilization. If we have problems in the double strand fragmentation, it could be recurrent miscarriages mainly, failed IVF, or poor embryo quality. We have also the opportunity to confirm with the sperm and urine culture, especially when we have oligoasteroteratospermia, leucospermia, severe astenospermia, or agglutination, or very severe hypospermia. It is necessary to identify if the infection is the cause. And of course, if that's the reason of the problem, we would give antibiotics and of course, double check with another culture test of urine and sperm before doing the treatment that the problem is solved. This is a rule to confirm prostatitis, and it is a possibility of freezing sperm after washing and trying to make our best that the sperm is not infected in cases where it is so difficult to remove the infection from the genitourinary tract. Other possible tests are chromosomed and FISH, and this test allows genetic status of the spermatozoa, so kind of karyotype in the spermatozoa. An ejaculate with high percentage of chromosomes disorders sperm could result in a higher number of aneuploid embryos, and that could lead to failures or even miscarriages. So, what are the potential reproductive solutions? Although each case is unique and treatment has to be personalized for each patient, we will look at some of the existing approaches in the following slides. So, potential reproductive solutions, for instance, IUI, only if good prognostic when the motile recuperation of the sperm is more than 6 million milliliter. Young women less than 38 years old with supposedly good quality of the eggs. Short infertility time considered less than 1 year, and we recommend between 3 and 6 cycles, no more than this, because the probability with IUI is around 25% per cycle, no more than this. We recommend IVF if the recuperation of the sperm, the REM, it's between 3 and 6 million per milliliter. And we can use conventional IVF, which means in a dish of the laboratory, put the eggs and the best spermatozoa around, so the natural fertilization supposedly should take place. And the normal IVF supposedly has the better neonatal outcome than ICSI, less perinatal problems, such as low birth and other problems, low weight birth. And ICSI, so a subtype of in vitro fertilization with intracellular sperm injection, it's necessary when we really need to have the maximum efforts to fertilize the egg. And this is imperative when we have less than 3 million per milliliter and when we have oligoasthenoteratospermia, and the normal rate of fertilization should be 80%. So another potential solution is pre-implantation genetic testing, so PGT. It allows us to select the best chromosomally healthy embryos, and it is a prescribed technique when the karyotype or chromosperm or fish is abnormal. And of course, it's also recommended when fragmentation is greater than 80%. So we have the potential other solutions for azoospermia and severe oligoasthenoteratospermia cases. So in this context, very important, we will identify with the urologist if, because of different parameters such as how it is the volume, how it is the pH, how it is the hormones of the man, if we do a testicular biopsy to try to obtain sperm from the testicle to try to improve chances. So the TESA is a testicular sperm aspiration, and it is a surgical intervention for male patients with no sperm in the ejaculate, and it consists of removing spermatozoa through a testicular biopsy. And it could be because we have obstruction in the epididymal or we have agenesia of vesicles. So depending on this, the urologist will give you the recommendation. As I said, we also recommend having FSH and LH hormone testing in the blood tests, and also detecting if the possible disorder is due to Y chromosome microdeletion. In this context, again, we will confirm if the problem is a hypogonadotropic hypogonadism, which means that the testicle is not working because the brain it's not giving the function, the hypothalamus hypophysis is not giving the function of the testicle, then we will use gonadotropins if LH and FSH blood test it's low. But if we have normal FSH or even high, we couldn't have a benefit using gonadotropins, and we will use testicular biopsy if the urologist considers that. So if we talk about Y chromosome microdeletions cases, these are losses of small fragments of Y chromosome, and it's one of the genetic causes of male infertility. These are not always linked to azoospermia, and we can describe 3 phenotypes. We have ASFA, which is Sertoli syndrome, 5% total. AZB, which is ermatogenic crypto or azoospermia block, and azoospermia AZFC, 60% total from severe to oligo to azoospermia. So the type A and B, it could be that there is a possible absence of spermatogenesis, so we will always recommend sperm bank. If it is AZFC, if there is a spermatozoa, it could be that patients could obtain babies with the sperm doing ICSI or even PGS, but understanding that we could transmit this to their future children. Sperm bank. When there is a severe case, there is the option of relying on a sperm donation. And Tambre has the oldest sperm bank in Madrid. Technologies such as PhenoMatch ensure, thanks to artificial intelligence, that the physical resemblance between the father and the donor will be, of course, guaranteed. Techniques such as genetic matching ensure genetic compatibility if we want to reduce the maximum probability of recessive diseases in the baby. And by law, sperm donation in Spain is anonymous, altruistic, and a voluntary act. Tambre's selection of donors is rigorous and includes medical visits, psychological examination, and tests for diseases that could affect the patient's offspring. Conclusions. So the existence of the male factor doesn't have to be a taboo, and it's becoming an increasingly normal situation. In fact, in Spain, 20% of cycles with fresh-out eggs were performed due to reproductive difficulties of the men, and 20% due to causes involving both members of the couple. Each case needs to be studied uniquely, and trust in a clinic that has the relevant technologies and techniques and has a multidisciplinary team will really help you in your project. And counseling of treatments and pregnancy rates. So thank you very much, and we can start with your questions.
Thank you so much indeed for your explanation and all the details you have provided. And now, yes, it's time for your questions. There are some questions ready. However, if you haven't asked anything yet, you know what to do. Our Q&A session is about to start, so don't hesitate. And I'm sure it's going to be a useful session for you as always. Thank you once again, Dr. Garcia. And I think that we can go ahead with the first question. So here's the first one. What is the normal range of DNA fragmentation test?
So it really depends on what fragmentation test you use. In the COMET fertility, it is less than 60%, even though the ideal is less than 45 for normal natural pregnancy. So having sex reports, but before doing treatment in the laboratories, consider less than 60% if we do COMET fertility tests.
Okay. Thank you so much, and let us know if that answers your question. I believe it does, but of course, let us know. And we have another question here. And what this is a follow-up here, right? And what is the treatment of it if it's abnormal? Sorry.
So the treatment, if it's abnormal, should be, if it's so abnormal, trying to improve with a new cycle of spermatogenesis that would take 3 months, trying to change lifestyle, trying to reduce coffee, tea, chocolate, cigarettes, alcohol that could affect this, trying to increase ejaculation, and using antioxidants such as zinc, vitamin E, and also using turmeric. So every single patient, depending on the result of the fragmentation, so the number, the rate, and if it's a single or a double abnormality, will have a counseling of what to do. If we need to improve with a new cycle of spermatogenesis, or if by contrast, just doing specific filter the day of the fertilization. So try to exclude fragmentation, such as the chip fertile, the zymoc, could be enough.
Okay, thank you again for that. There's another question here. What about ROS? I'm not familiar with this. I'm not sure. So here, test, and also what is the normal range and what kind of treatment for this?
So ROS could be reasonable talking for, testing the sperm that it's like dead. So it depends also on every single case if we need to do this or not, and then what kind of fertility filter the day of the fertilization we need to use.
Okay, thank you for that. And next term, I'm not familiar exactly, so please have a look. Spermatid for fertilization. Can we use it? Are you familiar with that?
Supposedly, it's talking about germinal spermatozoa, so it's not like the peripheral spermatozoa and mature. So spermatids, supposedly, they cannot be used because they need a minimum of maturity.
Okay, thank you for the clarification here as well then. And now we will go for DNA fragmentation. Question on that. So what causes DNA fragmentation? Is it curable? Anesthesia recommended to overcome that?
So that's a very common question. The DNA fragmentation, again, could be because genetically or how they produce the sperm, if even they have varicocele, but also it could be external. So depending on the lifestyle, if we have a lot of coffee, if we have a lot of tea, if we have a lot of chocolate, if our abstinence it's very long. So of course we will study on that case in particular, and we will recommend, if necessary, a new fresh sample after 3-4 months, even perhaps testing again fragmentation, and if necessary, using specific filters. Normally, testing, it's not the solution.
Okay. Okay, thank you for that question. And let me have a look. Next question is here. So, what is the risk of infertile sperm DNA fragmentation for older men? 60 years old.
So, supposedly, men with advanced age have more risk of high fragmentation. It's not the only possible problem. It could be men with more than 60 years, they have normal sperm, normal fragmentation. But we know people having more than 60 years, they have more risk to transmit problems such as autism in the babies. So if we talk about fragmentation, it is always necessary to be confirmed. We have more risk of fragmentation with other people, but it's not like sure that this is going to be abnormal.
Okay, thank you once more for that. Next question from the previous patient here. So how can we calculate REM?
So that's a test that is done in the laboratory with our experts, and supposedly they are the experts that give us the REM, how it is with a combination of the volume, of the concentration, and of the mobility.
Mm-hmm. Thank you for the clarification to this as well. And let's have a look. So next question is, so can tests be done to test if the DNA in the sperm cell itself is normal? What is the chance that it is healthy? Can, example, autism be detected?
So it seems we are starting to create more tests to make sure if it is a risk to use that sperm for the future babies or not. But supposedly, if the DNA fragmentation and the fish is normal, we could go ahead, understanding that there is always a risk of more transmitting these diseases in the baby. But again, Caroline, we're starting to have more and more studies of how
Yes.
to counsel this kind of couples and patients.
Mm-hmm. Okay, that sounds promising as well. Thank you so much for that. Okay, next question is here. So, how much higher is the risk in older men? Big risk or still small risk?
So the risk, especially, it's for autism. I cannot give
Mhm.
you the exact percentage, but we know that this is increasing in the last years. We cannot say uniquely because of the advanced age of the men. It is possible considered and linked to the use of laboratory techniques itself. But we know in this kind of patients, we have more risk of autism.
I understand there are some studies done that can already prove it and show it, and that advanced paternal age, then, right? Of course, increases the risk. Okay, I'm waiting and just wanted to see if there are more questions. At this point, we don't have more questions. However, if you wish to ask anything else, you know what to do. We still have time. And let me just have a look, but I think that we already answered lots of different questions. So let me see. And again, if you have any more questions, go ahead. This will be the final call for them. If not, we will be finishing for today. But I'm glad that we've discussed this particular topic with Dr. Garcia today. Dr. Garcia, anything you wish to add? I don't see more questions. I guess we will be coming to an end. So anything else you wish to add?
I can say that we have a very good team with the laboratory with very good technology. So this is quite reasonable, easy to help patients with severe abnormalities. We cannot say 100% because there
Yes.
are severe abnormalities that needs sperm donation, but we have very good laboratory, very good experts to maximize. And I have had results of babies with patients with very severe abnormalities. So just consider coming and we will help you.
That's great to hear, and I guess that's always good and encouraging to everyone that there are ways to improve it. There are ways to do it still. So thank you so much, Dr. Garcia, for adding that. And one more question. So let me show you what is your maximum age for women using egg donation is at
50,
Clinica
yeah,
Tambre. Over
50.
50, over 50, it's no not possible, right?
Yes, we always, there is not a limit in Spain, like
Right.
legally in age. There is like an agreement between clinics,
Mm-hmm.
like to when we are more than 50, not to do it. But of course, we always take into consideration and do consultations.
Of course. Thank you. In the meantime, one more question, probably our final one. So, abnormalities in the head and tail of sperm are dangerous for embryo? If so, how to improve it? Any vitamins you can recommend?
Thank you very much. So if the abnormalities are very, very common, we don't need to expect 90% of normal sperm. So if we have 3%, 4% of normal sperm, we don't need to worry about it. Only if we have 0% or 1% of normal sperm, then yes. And then we should comment with the laboratory what kind of abnormality and what needs to be done. But unfortunately, vitamins should be working more for fragmentation than for the problems of the shape.
Okay, thank you. Thank you so much indeed for this final question, it seems. So thank you so much. And before we finish, I also would like to ask everyone, because we are, and there is a thank you, of course, from our patient. Someone is typing, so let's give it a second. But in the meantime, perhaps I will take this time and ask everyone if you wish for us to discuss any of other topics. There is a question, so let us know if there are any other topics you wish for us to discuss. We'll be happy to have a look at them. We are preparing all the topics for next year as well. So if there is anything that you think might be good to discuss and you wish for us to discuss it, just put this in the chat, or please get in touch with me, Caroline at EuropeanFertilitySociety.com, and then we'll be happy to take a look at this, and any suggestions you have. Just type this now, or you can do it, of course, later on. Also, when you receive the email after this webinar, I can only encourage you to do that. And in the meantime, we did receive one more question, so I guess we can still have a look at that. So let me show you. So what food would you recommend for sperm DNA fragmentation?
So it's more to reduce coffee, tea, chocolate, Coke, alcohol, cigarettes, but also try to improve the lifestyle, doing gym, trying to eat like antioxidant aliments. So a lot of fruit, a lot of vegetables, fish, trying to exclude mainly toxic such as cigarette, alcohol, coffee from the diet.
That sounds good. Thank you so much indeed once more for adding that. And as you can see, more thank yous are coming your way, Dr. Garcia, for sure. So thank you indeed. And as I mentioned, remember that if you have any other topics you wish for us to discuss, just let us know. And I guess we can still have a look at our next topic. We will talk about non-invasive PGTA. So if this is a topic you are interested in and would like to learn a bit more, next week we will be back with Dr. Garcia España from Vista Hermosa Clinic. So I can only encourage you to join us and of course register. You can do it on our website, My IVF Answers. This has been recorded, and of course you will have a chance to watch this, and it will be available on our YouTube channel tomorrow. So thank you everyone for your questions, for joining us today. Dr. Garcia, as always, a pleasure. Thank you so much for joining us today. I know it was a last-minute call for you, so I'm glad that we were able to discuss it and all went well for sure. So thank you, everyone. Enjoy your evening, and I hope to see you here next week. Okay? Thank you. Take care.
Thank you.